Hello, and welcome to the Clinical Care Options Infectious Diseases podcast. I'm your host, Daniel Reynolds. This episode features expert insights from a webinar titled COVID-19 Update, Independent Conference Coverage of ECCMID 2023, featuring Dr. Patrick Mallon, Professor of Microbial Diseases at the University College Dublin in Dublin, Ireland. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Mallon has to say about new data on COVID-19 from ECCMID 2023.
Hello, everyone, and welcome to this presentation on feedback from ECCMID, which is one of the largest, if not the largest, European infectious diseases conference that was held recently in Copenhagen in Denmark. One of the knowledge gaps that we've had with Remdesivir is its safety and its efficacy in people with chronic kidney disease, and specifically in this study called REDPINE, the study focused on the use of Remdesivir in those with an eGFR less than 30 mils per minute. So this was a double-blind, randomized, multi-center, placebo-controlled phase 3 trial. Well-conducted study. You can see that there was a randomization of about 2-to-1 for Remdesivir IV versus a saline placebo. Approximately 163 people that received Remdesivir and 80 that received placebo. To be enrolled in this study, you needed to be over the age of 12. You could have either chronic or acute kidney disease with an eGFR of less than 30, and you needed to be diagnosed with severe COVID-19 pneumonia. Now, the severity was established by the definition of an oxygen saturation less than 94% in room air or requiring supplemental oxygen. And it should be noted that those people who required invasive or non-invasive mechanical ventilation, ECMO, or renal replacement therapy for acute kidney injury were excluded from the trial. Primary endpoint was day 29, all-cause mortality, or progress to invasive mechanical ventilation. What the study showed in terms of its primary endpoint, which was the all-cause mortality, progression to non-invasive ventilation, you can see from the graph here that there was no significant difference between Remdesivir versus placebo. Arguably underpowered to detect differences in efficacy. If the study had been performed back in March 2020, it probably would have been powered given that the mortality that we're experiencing there, but we're looking at a different variant of virus now. We're looking at populations that are mostly vaccinated, so it's much harder to demonstrate mortality endpoints. Even when the study looked at subgroups, which I think are important to look at, for example, the difference between those with acute kidney injury and those with chronic kidney disease, or between those with chronic kidney disease and those with end-stage renal disease, you can see that the hazard ratios for all of these, the confidence intervals all past 1. So we're not seeing any significant between-group difference between use of Remdesivir versus use of placebo in these subgroups of patients with renal failure. What the study was able to show, which I think is quite useful for clinical practice, however, is the reflection of the safety of the use of this drug in people with an eGFR of less than 30. And what you can see here is the list of adverse events. So this is any treatment emergent adverse event, TEAE, including those that are greater than grade 3, those that were thought to be related to the study drug, serious treatment emergent adverse events, and then those that resulted in discontinuation of study drug. And you can see that when you look at these treatment emergent adverse events, you really don't see any significant difference in the proportion of subjects in either group that experience these, whether it's a grade 3 TEAE, which was experienced in 63% of the Remdesivir group versus 61% of the placebo group, or serious treatment emergent adverse event, which is experienced by 50% in each of the groups. You do see slightly more treatment emergent adverse events leading to discontinuation of the drug in those on Remdesivir versus those on placebo. Similarly, when you look at treatment emergent deaths, you don't see any significant difference between groups, which demonstrates a safety profile which would certainly support the use of Remdesivir in this patient population should there be a clinical indication for its use. Another interesting study that was conducted and presented at the conference around use of Remdesivir looked at data on use of Remdesivir and readmission for COVID-19 in a group of immunocompromised patients. Again, another group of patients in which we still see severe COVID occurring in, a group of patients that we still have significant data gaps in. There have been some studies that have looked at use of Remdesivir in immunocompromised patients, but they've been relatively few. And a lot of the studies that have been presented to date really lack the sample sizes that are required to provide definitive outcome measures beyond the immediate outcomes. So to try and get across that, one way of doing this is looking at more real-world evidence. And a way of looking at real-world evidence is to look within retrospective observational studies. So in this case, this study looked at a US health insurance database, which has the ability, because it's collecting fairly harmonized data across a large number of individuals, to give you some snapshots or some insights into what's happening with use of drugs. The limitations to these sorts of studies is the fact that you're limited by the detail that's contained within the healthcare registry. So it can give you some broad insights, but is often lacking in detail. Now, this was a retrospective cohort study. What this study included were two groups. They had a group that received Remdesivir and then a group that didn't receive Remdesivir. And the group that received Remdesivir were classified as that group if they'd received greater than one dose at any time during their hospitalization. Now, the two groups were matched for age, for sex, for their date of COVID-19 diagnosis, which is important in terms of the difference over time in terms of infecting variants, but also in terms of modifications to treatment of COVID and vaccinations. The days in hospital before the match date, whether they required oxygen support, their ICU status, and admission and comorbidities. So one of the advantages here is that you're able to already correct for a number of the potential major confounders that could be looked for within this group. And then the endpoints here were all-cause hospital readmission through days 30 and 60 after the initial COVID-19 diagnosis. Now, what this study showed overall within this table was that the Remdesivir group experienced fewer admissions at days 30 and days 60s overall. Now, this was seen in the overall population, but they were also able to split this between two periods, a period of time when the Delta variant of SARS-CoV-2 was predominant, and then a more recent period where the Omicron variant was predominant. And you can see here, if you just walk through this, you've got 30-day events. And when you look at the first three columns, this is for the overall study. Those that received Remdesivir, there were 1,572 events. Those that received no Remdesivir, there was 1,722 events. And you could see that the hazard ratio for protection was 0.84 and quite tight confidence intervals, which would suggest that difference is statistically significant. And you can see that that's also been observed at the 60-day admission rate. And this was seen both within the Delta variant. You can see the hazard ratio there of 0.89 and 0.87, together with the Omicron variant, 0.86 and 0.84. So these data would suggest that there is at least an association between having received Remdesivir and these subsequent readmission rates. Unfortunately, what the data don't tell us is what these readmission rates were in relation to, in what way the use of Remdesivir contributed to the readmission rates. And as with any retrospective analysis, these data are always subject to bias, especially recall bias. So these are data that I think are useful, but they're useful in terms of identifying a signal that should really be followed up in adequately designed and conducted prospective studies. Lastly, in terms of vulnerable populations, another question that's been asked is when we look at nirmatrelvir and ritonavir, one of the issues around nirmatrelvir and ritonavir treatment is the significant risk of drug-drug interactions, which, especially in people who are immunosuppressed, can make use of this drug quite tricky. And a question has been asked, well, we can't use this drug. Are there alternatives? Can we reuse some of the old drugs like Molnupiravir? And in this study, these are patients with hematological malignancy who would be at high risk for severe COVID-19, in which you have nirmatrelvir and ritonavir, which is approved by use by the EMA, while Molnupiravir is not. But there is a question as to whether or not the Molnupiravir could be useful in this population because of its lack of drug-drug interactions. Again, a retrospective study, but this was a retrospective case control study. Adult patients with lab-confirmed COVID-19 active hematological malignancy within the past 5 years, and this was taken from a European registry. So the cases and controls were matched for sex, age, and the status of hematological malignancy at the onset of COVID-19. And similar to the previous studies, what we see here is no significant difference in overall survival probability or at any time point up to day 90. So here you have the 4 graphs here. You're looking at day 30 survival probability, day 60 survival probability, day 90 survival probability, and the overall survival probability. Now, the thing to notice about the numbers is that once you start to move out towards the day 90, you can see that the number of those that are actually involved reduces down, and particularly with the overall survival probability. When you look at it, the days 200 and 300, you see that the overall number of people that are contributing to those time points is quite low. So the richest data here really relates to the day 30 and day 60 survival probability, which suggests that both of these medications are very similar in terms of the benefit that they may offer to people with hematological malignancy at risk for severe COVID-19. So what can we take home from these studies? Well, firstly, use of Remdesivir in patients with AKI, a chronic kidney disease, or those on end-stage renal disease wasn't associated with any concerning safety signals. And what that would suggest that for physicians who do want to treat people for COVID-19 who have an eGFR of less than 30, that there shouldn't be any dose adjustment needed. The very intriguing data from a large healthcare registry of immunocompromised populations that suggests that there may be an association between use of Remdesivir and decreased risk for readmission at 2 time points, but also in 2 different time periods. And the persistence of that signal suggests that there may be something real within that, and it's probably less likely to be due simply to confounding. And then lastly, the lack of observed mortality difference in people with hematological malignancies based on whether they were treated with nirmatrelvir and ritonavir or alternative agents. And it does suggest that there may be options for alternative agents in those who are unable to take nirmatrelvir and ritonavir because of drug-drug interactions. Okay. Moving on then, management of patients with severe COVID-19. What data came from ECCMID in this regard? Well, probably the most important was the updated data from the recovery study, which explored the use of higher dose versus standard dose corticosteroids in hospitalized patients with COVID-19. I'm sure most of you are familiar with the recovery study. This is an ongoing international open label randomized platform trial. And by platform trial, what we mean is that people are randomized to various different types of treatment where the comparisons are what would be called usual care. This has been a very important type of trial design in COVID-19 because it's enabled us to explore simultaneously a large number of interventions. And the recovery trial has been instrumental in shaping some of the fundamental approaches to the management of COVID-19, including the use of dexamethasone and the survival benefit that was associated with that. So what this analysis attempts to do is to say, okay, well, our standard approach to the use of dexamethasone, which is to use 6 milligrams once a day for 10 days or until someone gets better, is that enough? Or should we actually be trying to maximally dampen down the inflammatory component that's driving severe COVID-19? And To explore that, what Recovery wished to do was to compare the standard dose corticosteroids, 6 milligrams daily, to a higher dose of corticosteroids, which was 20 milligrams once a day of dexamethasone for 5 days, dropping down to 10 milligrams once a day for a further 5 days. Study population were adults who were hospitalized with COVID-19 who were hypoxic, receiving no oxygen or low flow supplemental oxygen. So although maybe classified as severe disease, these are still a group of patients that you would expect if they're going to get worse, that they would progress to the need for things like mechanical ventilation or non-invasive ventilation, which were part of the outcomes. So primary endpoint, a hard mortality endpoint, so day 28 mortality amongst all randomized participants, with the secondary outcome being the time to discharge from hospital, composite endpoint of mechanical ventilation or death, and other outcomes included need for duration of mechanical ventilation at all, need for renal replacement therapy, or the number of patients with thrombotic events, which is very common in severe COVID-19. So what did the study show? Well, what you have is a graph here that looks at the primary outcome, 28-day mortality. And in the blue bar, you have the higher dose steroids. In the red bar, you've got the standard dose corticosteroids. And you can see immediately that there's a very significant difference between the two. The two graphs clearly separate. What we observe in the blue bar is a much higher mortality with the higher dose steroids. And when you look at the risk ratio at the bottom of the graph, it's 1.59, so approximately 60% higher mortality. But the confidence intervals don't cross 1, which means that it's statistically significant. So this was our primary outcome. When you look at the secondary outcomes with regards to invasive ventilation or death within 28 days, the higher dose had 131 events, standard dose had 80 events, risk ratio of 1.52, so 52% higher in terms of invasive ventilation or death. In terms of median duration of hospitalization, no difference. And in terms of those that were discharged alive from hospital at 28 days, no difference, really reflecting just how particularly unwell this group of patients are. So why did this happen? Well, the key insights into why we ended up with worse outcomes from higher doses of corticosteroids really lies when you look at the adverse events rates, so the safety events, and in particular, infection-related safety events. And it's clear from this graph when you look at the non-SARS-CoV-2 infection rates, particularly pneumonia, and a lot of these people would have been at higher risk of pneumonia because of the need of invasive or mechanical ventilation. You can see that the number of events much higher, 64 versus 37. Other infections, such as urinary tract infections, also slightly higher. Bloodstream sepsis infections, 7 versus 3. And again, the pattern here would suggest that at least the signal is that with higher doses of corticosteroids that you're driving up infections. Secondary to that, not unexpectedly, we also see hyperglycemia requiring new insulin use. A slight signal around cardiac arrhythmias, but really most of what we're seeing here is being driven by infections in those that are on higher corticosteroids. There were some other data that included some information on other use of other immunotherapies. There was a nice study from Hungary. Now, this was a single center study that looked at patients who were treated with either tocilizumab or baricitinib for severe COVID-19. This was an open label single center study. Patients were, it's a non-randomized trial. Patients were presented with severe COVID-19, had to have a related cytokine storm, and they were either treated with tocilizumab or baricitinib. Primary endpoint, all-cause mortality at day 28. Secondary endpoints included the requirement for invasive ventilation or major infectious complications, which has always been one of the concerns with the use of these immunomodulatory drugs. So what did this study show? Well, baseline characteristics were fine between the two groups with one major confounder, and that was the timing of the drugs. So those that received tocilizumab tended to be treated earlier in the COVID-19 pandemic. So this would have been before the use of dexamethasone came in. Probably also when there were less vaccinations, for example, and also potentially when there were variants of COVID-19 that were associated with a higher mortality, and they're pretty big confounders. So even in the setting of those confounders, you can see that the survival probability here, very wide confidence intervals within the survival probability, and no significant difference between outcomes, either in those treated with tocilizumab or those treated with baricitinib. So unfortunately, this data really doesn't offer a huge amount of beneficial information to tell these two drugs apart, mainly because of the study design and that confounding through time. What they did show was a significant difference for the requirement for invasive mechanical ventilation, with 52 or 51% of tocilizumab receiving participants ending up with requiring invasive mechanical ventilation versus 27% in the baricitinib. But it's difficult really to put these results in context given the study design limitations. So take-home points from these slides: avoid higher dose steroids. Recovery is a really well-designed study, very clear data, very clear differentiation in mortality, and it's something that we should avoid. What we do see, though, is when you're treating with either tocilizumab or baricitinib, I'm afraid the jury's still out. The study that I showed you really doesn't show any significant difference between the two. And what we really need are properly conducted comparative randomized data. Okay, so moving on, the last section, we're really, there's a little bit of data in terms of what's up and coming with regards to new treatments. There are two new drugs that were presented at the conference. We got Ensitrelvir, which is a drug that's really coming through from Japan, produced by Shionogi. It's a protease inhibitor. It's currently in phase 2, phase 3 trials, and there was data presented at ECCMID from the Scorpio study. And then there's Bemnifosbuvir. Bemnifosbuvir is a guanosine nucleoside analog. And there was a phase 3 data from a phase 3 trial presented from a study called the Morning study. And then we also had some interesting data presented from a couple of vaccines. We've got MB2155, which is the adenovirus vaccine. That's from Guangzhou in China. It's an intranasal vaccine. And then we had some comparative data, the AstraZeneca beta variant vaccine, 2816. We had a Novavax combined influenza COVID vaccine. And then we had another one I don't think we're going to cover, though, the R910 self-amplifying RNA vaccine. So I'll show you a couple of slides from these, from each of these studies. So just starting off with the AstraZeneca vaccine. So the 2816 and the 1222, which was the sort of primary AstraZeneca vaccine. Now, what this study aimed to do was to see if this 2-dose primary series of COVID vaccinations would actually result in good immunogenicity when you're looking at it, and to see if there was any difference when you compare a vaccine that's been specifically designed against the beta variant versus the AZT1/2. So this was a double-blind phase 2/3 trial conducted in Brazil, South Africa, Poland, and the UK. But when you look at the proportions, the vast majority of subjects actually came from Brazil and South Africa, mostly young and predominantly men. What the study showed really was that both of these vaccines resulted in very good immunogenicity. The neutralizing antibody GMT ratios were 1.19, so they were very close, and very little difference in terms of the seroresponse rate. So this is the sort of vaccine efficacy. When you look at The nucleocapsid seroresponse rate at day 28 and at day 180, you can see that they're very similar between the two vaccines. So these vaccines tend to behave in a similar fashion. And certainly if we were to see another beta type variant emerging again, this would certainly suggest to be a good vaccine candidate for that purpose. The qNIV COVID-3373. This is a very interesting approach where they've actually combined COVID and influenza vaccines into a single vaccine. So this was a dose-finding study, phase 1/2 dose-finding study of a 2-dose combined vaccine, administered 57 or 56 days apart in over 600 people. Median age, 59, 40% of people female, and 100% of people had already received a COVID primary vaccine series. So really the focus of this phase 1/2 study was really focused on safety. So looking at reactogenicity, looking at any adverse events. And really what they found was, other than what you would expect to see with localized pain and some malaise, there really were no significant serious adverse events with this combined vaccination. And then from an efficacy perspective, really the focus was looking at immunogenicity. And it looked as if this combined vaccine actually produced very good immunodeficiency against both SARS-CoV-2 and influenza. And this is certainly a novel approach that may be useful into the future, if indeed, as it's expected, that SARS-CoV-2 becomes a seasonal virus, although I'm not quite sure that we're at that stage yet. Then we have the Novavax study. So there's a Novavax study in people with HIV. There's always been a question mark over how well vaccines work in people with HIV and whether there's any difference in immunogenicity of vaccines if someone is living with HIV who's either well controlled with a good CD4 count and an undetectable viral load, or less well controlled. And in this particular study, they looked at well-controlled versus less well-controlled based on contributions from both CD4 and viral load. And what they found was that when you look after one dose, you do see a difference. So those with better controlled HIV had a better immunogenicity when measured by IgG levels. But that difference was really negated with the second dose of the booster. So as we're seeing quite often with a lot of the COVID-19 vaccine studies, the immunogenicity is really powerful. And once you get that second dose, or in some cases the third dose, you start to see really a disappearance of vaccine efficacy in people with some specific immunodeficiencies, but not all. So the take-home points on the novel antivirals and vaccines. Well, the antivirals that are in development, they do target new mechanisms of action. They may address unmet needs for ambulatory patients with mild disease, including symptom worsening and viral rebound. I didn't get the chance to go through the data on Ensitrelvir, but when you look at the data that's there, the data would suggest that it's you do see some viral rebounds in Ensitrelvir when it's used. The data from the phase 3 study showed that it actually does result in abrogation of symptoms faster. So it enables people to recover from COVID quicker. There's always this concept of whether you're going to end up with rebounds. Study did show some rebounds. The overall number was very small. And quite often these rebounds, when they went looking for them, they weren't really associated with significant rebound in symptoms, even though the virus was detectable. And in addition, when they went to culture the virus, they could very rarely get culturable virus taken back from these individuals. So the data looks good for these drugs in terms of viral rebound. Bemnifosbuvir, the guanosine nucleoside analog, the phase 3 study in Bemnifosbuvir, the Morning Sky study didn't show a huge benefit when it was being used in early COVID-19, which was disappointing to some extent. But what it did suggest was that from a readmission rate, that there may be an impact. So the group that have developed this drug are going to continue looking at this within a phase 3 in a sicker, maybe a population that's more at risk of severe disease. So the drug hasn't been, certainly doesn't seem to have the same impact on early disease as the protease inhibitors, but there's still some unanswered questions about where it's best placed. And then we've talked about the novel vaccines. Novel vaccines are addressing the emergence of variants, waning antibody responses, and also this novel combination where one combined injection with 2 vaccines is offering good immunogenicity against 2 infections at the one time.
Thank you so much, Dr. Mallon, for that great presentation. It looks like we have a couple of questions that have come in from the audience in the chat. The first question comes from Susan. She is asking about, particularly in some of the treatment studies that you covered, was the vaccination status of the patients included in some of those recent studies, particularly for some of those with underlying registries?
Yeah, it's a really good question. And from looking back through the data, the 2 studies that tended to have most data available on vaccinations were the 2 trials of the novel antivirals. So the Ensitrelvir and the Bemnifosbuvir. And in both of those studies, the vast majority of people had received vaccination against COVID-19, which it's that change in environment in terms of the vast majority of people having received vaccination together with the change in the pathogenicity of the virus that's probably impacted on the ability of these studies to be able to demonstrate a treatment benefit, which I guess is one of the reasons why Bemnifosbuvir is moving on towards trying to address the point within more vulnerable populations. But the fact that Ensitrelvir is still able to demonstrate a benefit in even mild disease in terms of the duration of symptoms, I think is an encouraging sign in that context.
Great, thank you. And one question coming from Gary, he is asking about vaccination in older patients. Should they now get their second bivalent booster or wait until the fall for a possible updated vaccine?
Yes, so Gary, that's an excellent question. It's the $6 million question. The key is when should we, what is the optimal timing of a booster vaccine? And it's one that we really don't have a clear answer for. As you know, the main reason for providing someone with a booster vaccination is to prevent them developing severe disease. And up until this point, we've tended to use natural history data for waning immunity to try and give an indication of when at a population level, when people's antibody levels drop low enough that they may be at risk of severe disease. The key question here is how low does an antibody level need to drop? And that's what we just don't know. There's this concept of a threshold of immunity. And there's certainly a lot of data that's been generated in this. And certainly the data that our group has generated that has shown that when you look at the neutralizing capacity, that's the equivalent of a vaccination, that corresponds to an RBD titer, so an antibody titer of somewhere between 500 and 1,000. But that hasn't been confirmed in prospective trials. And I think that really is where the field needs to go, Gary. We need to figure out, is there a threshold antibody level below which vulnerable people are more at risk of severe disease? And if that's the case, when does it happen? And that's the time to booster vaccinate people. Whether that's the fall or whether that happens midsummer, we just don't know, because at the moment, COVID still hasn't transitioned into a seasonal respiratory virus. So I guess it's watch this space. There's a lot of people still working on this, and hopefully we'll get some answers before the end of the year.
And Dr. Mallon, there was one last question that came in from an audience member, Richard, on a similar vein. How often should a patient who is greater than 65 and immunosuppressed due to medications be boosted against COVID-19? Similar answer?
Similar answer, Richard, the key here is that if we can identify and establish a correlate of immunity, so if it is this RBD titer of 500 to 1,000, then the answer is that if you're at risk, if you're immunosuppressed and your RBD drops below that level, that's when you need to be boosted. And that's the data that we need to generate. And probably the best way to generate that is either through ongoing vaccine trials. I head up a trial called BoosterVac in Europe. It's specifically asking the question in the general population, what is the ideal time for a booster vaccine? We're coming up to, we're just about a third of the way through recruitment for that international trial. But there are other studies that are ongoing that are looking at this in immunosuppressed individuals. And the other important consideration here, Richard, is that not everybody who receives a vaccine will mount an antibody response. So once we figure out what the threshold of immunity is or what the required antibody titer is to keep you protected, the key is we need to identify those people who are unable to achieve those antibody titers through normal vaccinations. And that in itself will generate further research and further studies.
Thank you very much to our faculty, and thank you to our listeners for joining in. To learn more about our coverage of ECCMID 2023, including slides and video, see link in the show notes. Please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.